Hello everyone, today's video is all about biofilms. Um, as per usual, nothing I'm saying in these videos should be construed as medical advice. This is all for informational purposes only. If you need medical advice, please ask your healthcare provider to get that advice. And if you don't mind taking a quick moment at some point to please like, share, subscribe, and or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. So there were several questions on some of my videos about biofilms, so I thought I'd just amalgamate them all and have another thematic video. Still working from home, my family members getting better every day, but still not quite ready to come home from the hospital, so I'm still spending a lot of time at the hospital myself. So anyways, working from home to try to save some commuting time, and anyways, hence the casual wear. So without further ado, so the first question goes, hello, would you know if any type of biofilm disruptors are specific for each type of SIBO? So if I use a type of biofilm disruptor, wouldn't it be effective for any microorganism? For example, archaeas, which I think is a reference to Archaeobacter, which would generally be the methanogens that drive methane gas-producing SIBO, also known as oh my gosh, IMO for intestinal methanogen overgrowth. So would I have to use a specific one? I heard a comment about this. So thanks for the question. Good question. Yeah, so my understanding is that biofilm disruptors are not specific to the organism. There's different types of biofilms, like phase 1 and phase 2 biofilms, which we'll get into in a little bit more. There's reference to that with the next question that's going to come up here. But outside of that, whether it's mold producing the biofilm, whether it's yeast, whether it's Archaeobacter, whether it's whether it's archaea, whether it's Cebobacteria, Libobacteria. My understanding is that we don't need specific biofilm disruptors to go after specific microbes. Now, as research is evolving in this area, what I'm saying it may very well be very outdated in 2 years, 3 years, 5 years. There might be other options, but I guess what it comes down to is, while there are a number of different agents that are biofilm disruptors, it seems that the phase 2 biofilm disruptors, like the strongest ones, tend to pack the most punch. They tend to work the best, and so at least clinically, it doesn't really seem to matter. And I'm not sure that it matters in general. But yeah, whether it's archaea or something else, then I don't think it really matters. So good question. So thanks for asking. And then the next one here is, it says, when you mention anti-biofilms for phase 1, do you mean that these are less effective when the biofilms are more difficult to treat, unlike those in phase, or I think maybe it means to say like those in phase 2? And what is the basis for this reason that, for example, NAC or some herbal is less effective than phase 2 antibiofilms? Is there anything that proves that there is this difference between the effectiveness and power of phase 1 and phase 2? So great question, and kudos for asking this question. It's like, don't take my word for it. Well, I guess you're kind of going to take my word for it, maybe, or considering my word for it since you're asking me the question. But yeah, absolutely. Where does this come from? Is this something that somebody cooked up in their basement? Phase 1, phase 2, all of this. So there's actually, to my understanding, quite a lot of research evidence looking at the difference between phase 1 and phase 2 biofilm characteristics. Phase 2 biofilms, to my understanding, are just quite a bit more elaborate. So kind of the analogy that I at least have in my head that I explain to patients sometimes is that, if you were, say, back in traditional medieval time, you're walking through the countryside, you come across a little village, and maybe they have just a wall around the village that's just made up of sticks, maybe some sharpened sticks or something like that. There's a wooden gate, a couple of sentries, piece of hay sticking out of their mouth. It's just pretty pretty weak defenses, all things considered. It's going to keep the wolves out, maybe keep some small groups of bandits out, but a big army comes along and that wall's not going to stand up to much. Then you meander a little bit further across the countryside, and then you come across a huge keep, a castle. There's massive stone walls around it, lots of guards around, huge gates, this and that. That's going to be your phase 2, a lot more infrastructure there. That's going to be your phase 2 biofilm. So maybe that's a bit of an exaggeration in terms of stick wall versus massive stone fortress, but there's a big difference in terms of the infrastructure, because at the end of the day, to my understanding, phase 2 biofilms just have more time to they become more developed over time. They become more elaborate. The more microbes that can kind of join into the microorganism community that's living within the biofilm, it kind of adds to the strength and integrity. They kind of like pool their resources. They share resources, share genetic information between each other, at least within the same species, maybe between species. I don't know. And it's it's something that makes like a much more elaborate biofilm. So the phase 1 and phase 2 biofilms are very different from each other, and that's rooted in the research evidence. And then there are quite a few studies looking at the efficacy of different agents working against different types of biofilms, phase 1 versus phase 2. So when I've said things in the past, like where, herbal extracts that have aromatic compounds or proteolytic enzymes are good phase 1 disruptors, not so much with phase 2, well, that's based on the research literature indicating that. Whereas something like a chelating agent like EDTA or DMSA or DMPS, those are quite good at breaking down the infrastructure of a phase 2 biofilm. So that's based on the research literature. Now, with the studies that have been done, the vast majority of them, to my understanding, are in vitro, so in a petri dish. There are some animal studies, and then as far as like human clinical trials, I believe that there are some that are kind of underway. Maybe some have been done. I mean, I didn't just search PubMed or anything right before posting this video. There might be some newer stuff that's come out, but based on all the continuing education that I've done, looking at the research myself, attending lectures where doctors talk about this, who do spend a lot of time pouring through the research, because of course one person cannot look at all the research all the time. That's why we have conferences and journal articles and all these fun things and review articles, so we can all try to stay as educated as we can without just sitting in our rooms reading all day and not seeing any patients or anything like that. But anyways, there might be some information out there or studies out there now where they're actually looking at this in humans, but it's more like extrapolating from human trials with different agents that are known to have biofilm disrupting category or qualities that lead to clinical improvement. But we don't know for sure whether there's actually biofilm disruption. To my understanding, in part because it's really hard to test for biofilms. To my understanding, there's no commercially available test to actually test for those. I mean, there are some companies that do kind of talk about that. I'm just not sure exactly how clinically valuable they are. But that's maybe a video for another day. So bottom line is that, how do we know, or what is there anything that proves that there is a difference between the effectiveness? There are those in vitro studies. Now, devil's advocate would say, well, in vitro study doesn't tell us definitively what's going to happen in an in vivo study, what's going to actually happen in clinical practice, and that is absolutely true. Just because the study says, like, yes, DMSA is good at, breaking down this biofilm in the petri dish, it doesn't necessarily that's going to mean it's going to work in person or in a person. Just because an aromatic herbal compound doesn't seem to be that great at breaking down phase 2 biofilms doesn't mean that maybe at the right dose, right, surrounding circumstances, maybe that aromatic compound gets metabolized into like a really, really strong biofilm disruptor and actually is going to work really great, like way better than in a petri dish. So it's that kind of blend of like, we take what we know from the research literature, but then ideally take into account what we're seeing in clinical practice, what our patients tell us, what we observe, and then we combine that into a beautiful blend, and then use our best judgment moving forward. So thank you for the question, and again, kudos for just asking if this or that is true and where that information is coming from. The last one that I have here is it says so I had a video from 1 year ago called Treating Biofilms in the Bladder. And it says, what about the suppository for urinary tract infection? So I don't remember exactly what I said in that video. I've made quite a few videos in the last year, and I don't remember exactly what I said, but I figured I'd riff on this anyways without actually rewatching the video. So generally speaking, if there's biofilms in the urinary tract, with my patients, what I'd be thinking of is using silver, because silver hydrosol is very well absorbed. It gets excreted primarily through the kidneys, and so I have a high level of confidence that silver is actually going to make its way down through the urinary tract. So that would be kind of my go-to biofilm disruptor for UTIs. Now, the question about the suppository, it's kind of like, well, if there was a biofilm issue in the vaginal canal, and so this of course would not apply to male patients, but if there is a biofilm issue in the vaginal canal, then possibly using a biofilm disrupting suppository in the vaginal canal might be a good idea to help break that down and get rid of those biofilms, so there's not this ongoing source of microbes coming from the vaginal canal and then migrating up into the urinary tract. So that is a scenario that happens sometimes. But generally speaking, for UTIs, except in a case like that, we wouldn't really be using suppositories. So if there's a way to refine that question more, or if I missed something, just post in the comment section below and I will do my best to answer. Hope this was of interest, and I will leave it there for now.